using maybe curette or the ring curette or elevator. XL thin bone can be, pieces can be lifted off, or you can use the fine cuff forceps. Okay, and expose the nerve till it start curving medially. That means it is from the optic nerve, it is forming optic chiasma. So that is the posterior end. Till that you need to uncover the nerve and also uncover almost 180°. Okay, just taking out maybe 1 or 2 millimeter will not help. Incising optic nerve sheath, it has the advantage, it has a problem. The advantage is that the decompression is much better if you incise the sheath, but that is required if the nerve is edematous and if you are suspecting hematoma within the sheath. The chances of the CSF leak is high, as you all know that the sheath is containing all three layers of the dura, pia, and the arachnoid. So the CSF leak can be there, bleeding can be there, and also the trauma to the nerve directly by your incising the sheath can happen. The sheath has to be divided into supromedial quadrant, because the inframedial quadrant comes the ophthalmic artery, and also if your knife slips, then below lies the carotid, and sometimes carotid is dehiscent. There is no covering of the bone over the carotid. So important is the avoid the inframedial, inside the supramedial area. Hemostatic pack is to be kept and can be removed on day 2 or 3. Important thing is, don't keep your pack directly onto the optic nerve, especially if you have incised the optic sheath, because only by pulling, and if it is getting adherent there, it can cause trauma. So put some Surgicel or gel foam there, so that when you are taking out the pack, you will not be injuring the optic nerve. And afterward, one can do the douching and the endoscopic cleaning, suction cleaning of the area. Try not to touch the again optic nerve area. Steroid has to be continued initial 2 to 3 days, high dose, antibiotic for a week, normal saline irrigation 2 to 3 times a day for about 4 to 6 weeks, and nasal steroid also help in early healing and less edema. So this is a small video which is being given by Dr. Prem, who is additional professor in the department. So this is decongesting the middle meatus. Put pack and wait for 10 minutes. And also you can use injecting the Jalocaine with adrenaline. Remove pack. Okay. And then posterior part of the middle turbinate can be removed, so that the access to the ethmoids and the sphenoid improves. So this is sphenoethmoidal recess area. This is septum. This side is septum, this is turbinate, and this was the ostia. So this is middle turbinate which is being cauterized, and this is uncinate process. Okay. So you remove that part. And then you incise the uncinate process. Okay. So this is the area which is bulla. Okay. As you go in, you will remove the posterior ethmoid. Okay. And then you reach the sphenoid sinus. Okay. So one of the way to differentiate between the posterior ethmoid cell in the sphenoides always have the space or the depth. If you enter, you will get the gap there, where the posterior ethmoid is usually flat. You can see the floor, whereas sphenoid you can't see floor. So this is the posterior part of the lamina papyracea which has been taken off. Okay. So here the important point is you should avoid injuring the periorbita. If you injure, then the fat prolapse. If fat comes into your field, then the posterior access to the optic canal will be obscured. So this is the thick bone or the optic tubercle. So this need to be drilled. If it is thin, you can take it out. But when you are twisting, don't twist too much, because otherwise it will create pressure onto the optic nerve there. And now can you see, this is the orbital apex, and now this is the nerve. Okay. So now this slowly the chips are being taken off. This is the mucosa. So in this case, the drilling was not required. The elevator was enough to remove all the bony lining of the optic nerve. Okay, and can you see now this start turning? So this is the limit. You'll go and also remove 180 degree of the bony lining. So this is the keratico-optical recess. This is Surgery cell, just to cover that exposed nerve and the oozing edges of the mucosa. And then this is the ointment, which is just filled the sphenoid. So you don't want to put a pack there. Even if you want to put a pack, put very loose pack, because the whole purpose of decompressing will be defeated if you put a tight pack there. And then packing can be done in the nasal cavity. So with this, I end my talk, and I will be happy to answer any query or comments, if any.
Thank you, Dr. Rakesh. It was a very nice presentation. In the video, we saw that the middle turbinate was not removed. It was cut maybe at the junction of the body with the tail. So you can get away with that, I suppose. And why cutting there improves the exposure?
See, the middle turbinate, as an ENT surgeon, we say this is the most important landmark. So we want to preserve at least the attachment. Okay. So the area where you work will be the posterior part. So we have preserved the anterior end of the middle turbinate. The posterior part has been removed, so that the ethmoids area is exposed, and then you can work posteriorly. But as you say, if the exposure is more exposure is required, you can leave behind about, say, 0.5 centimeter attachment anterior most, and then you can cut the remaining turbinate. And also, as I was talking, the one of the landmark for the lamina papyracea is the bulla ethmoidalis. So bulla, the medial wall of bulla is closely related with the lamina papyracea. So that is the lamina papyracea. Just follow that. So that is the, once you open the bulla, the posteriorly will be, it will be entering into the posterior ethmoid. So this is how you will keep opening. And if the ethmoid cells are not inflamed or the disease, then it is very, very easy.
Okay.
So that is the advantage of taking out the part of the turbinate.
Very nice talk.
Yeah.
If you open the optic nerve sheath, is there any chance of CSF leak? And if CSF leak happens, what to be done for that?
I think neurosurgeon CSF leak is not a problem.
No, you told no, the packing should not be done in such
so-
cases.
So the
What should be
thing
done?
is, there are few indication where you deliberately want CSF to leak, like this the idiopathic raised
Intracranial hypertension.
hypertension, papilledema. There you make something like
Fenestrations
similar
in
to the glaucoma surgery,
Yes.
where you take out the piece and then you allow the vitreous to continuously drain. So that is what the very known surgery and very published also. So this is deliberately you done. Even if there's a leak happen, although the theoretically the chance of meningitis, but practically it is not. So even if leak is there, it should settle.
And traumatic optic neuropathy usually have two issues. One is either some direct contusion of the optic nerve, that is one, and second is some bony spicule.
Yes.
If we remove bony spicule, there is a possibility of improvement. But if there is only optic nerve contusion, in your experience, is there any possibility of improvement or?
See, there are multiple factors. One is if all other things are favorable, it should improve. Okay, contusion are there is hematoma, then better to open the optic sheath. Prognosis, if there was vision was there, patient come early is good. But you cannot say it will be 100%, how much it will improve. Like in any other nerve case, earlier you intervene, better will be. The from where you start, whether there's some vision was there or there was no vision at the time of surgery, the prognosis will depend on that.
That means it should be considered as an emergency surgery.
Yes, like for the ENT surgeon, like not an optic nerve decompression, like the patient where the ethmoid sinusitis is there and the vision is going down. So we say the window is half an hour. If vision start coming down, you don't wait. You immediately take up case. So don't delay.
Thank you, Dr. Rakesh.
Thank you.
So much.
About the optic canal length is about a centimeter.
Okay, including the intraorbital, intracanalicular portion, and then you need to include the intracranial portion also, or only need to limit up to
As
the...
an ENT surgeon, we stop once
at
it
the-
start turning into the optic chiasma, when it start turning medially. So you keep exposing till it start turning medially.
Okay, thank you.
Remove the optic nerve sheath. How do you incise it?
You take sickle knife,
Okay, just linearly.
yeah, and you start from posterior to anterior, okay, and supromedial. Thank you.
Yeah, thank you very much, sir. Thank you very much, sir, for beautiful lecture. I will request Deepak Agarwal, sir, to please felicitate Professor Rakesh, sir, with the flower and mementos. So thank you very much once again. Now we'll like we have completed the till optic now. Huh? नहीं वो छोड़. So like going yesterday completely through the step by step, things look very easy, and when you want to do it and want to go for it, and when you see that you want a case and things, and then you realize that yes, what fits in your mind may be not practical. That may not come in your hand. Your hand may not work what your mind is thinking about it. And that's the real problem which we are seeing for last 15 years. Myself, I can say that, like, simple cases creates more problem because of your learning curve, not knowing your anatomy, not having things clear, not spending good time in workshops and understanding the skills. This was the case referred to us. Like in one of OPD, patient came bleeding. We sent to evaluation, like patient was packed. Then we went through the history. 3 months back, patient was operated in some of the institute. They went in. They, like, you can see this is very nice pituitary tumor, right? You know, like laddu we call it. We can go and just grab it. But I mean, and you can see this well pneumatized sinus. You can find everything possible things what you want in the life, like very nice straight approach. You can have this very nice pneumatized sinus, small tumor, not going supracellular, no vision problem. You just go in and do it. They went in, what they did, like they missed it. Like you can see one of the septas going on to the carotid. So they, while removing that sphenoid septa, they just went in, used that, and then there was torrential bleeding. They packed it, and then they were waiting for it. Suddenly, like a 3-month patient waited, and then patient had epistaxis. Patient was referred to AIMS. We got DSA done. Then patient had this pseudoaneurysm. Imagine, like, patient was, we wanted to operate for this. Patient ended up into this aneurysm. We coiled it, and now patient don't want surgery for this small pituitary tumor. Not at all. At least his life saved. This is the real scenarios. One of the scenario what things can go wrong. So knowing anatomy is very important. So my talk today is like, I'll give a briefing like about how things are important for extended approaches. So extended approaches is the next level job. It's not, so yesterday we went through nasal stage, sphenoidal stage, sellar stage, and reconstruction. In this extended approaches, another stage is added, which is called intracranial stage, which we call cisternal stage, or we call tumor resection stage, where like you create more defect, you operate intracranially, sometimes you open third ventricle, and then reconstruction become another most important stage into this surgery. So you should be very like careful regarding the cases that you select, right? So like there are various like literature that we have published, and similarly this was another case. Like you can see this, like again sphenoid approach, you can go in, you can see that this is pituitary, I can just go and grab it, right? There is a direct approach and you can just remove it. But if you don't know the anatomy well, if you don't read the CT scan and MRI well, I mean you will land up into the disaster. There is no other way. You can see that in the para cut, it is going to the cavernous sinus, and more or less it is going into the anterior cranial fossa. Can you imagine it is nubbling, crossing it and going into it? If you just go here and try to decompress and believe that that arachnoid will fall and it will just land everything in your hand, it doesn't happen that way. This patient was operated and ultimately this could not be removed. It swelled, patient has optic compression, and we had to, well, I mean, this was like, that's the history, had to transcranially operate. So every case is different. Every case is different. So just tips like, one of the most important thing for the beginner, you should select your cases. You should know your anatomy very well. Worst patients, like if there is a no good pneumatization, if you have acromegaly, Cushing disease should not be chosen because they bleed a lot. And if the recurrent dumbbell tumors, please don't touch in the initial period because they create the problem. Review your anatomy very well. Similarly, assessment of nasal airway, anatomy of paranasal sinuses, like extent some pneumatization, and again, like yesterday we had DNS. So understanding that how much of cavity is there so that you can operate or not. And then sella, is it enlarged? Is it erosed? What is the anatomical variations of the sella? What is the status of the carotid and the pituitary? Yesterday, like lot of cadavers, you have noticed, like when you went in and carotid was bare, 10% of cases there is no bone on the carotid, right? So it was visible yesterday, like a lot of the cases, and there are a lot of variations. Some had onody cells, some like, so you should be very important. And like for onody cells, sir had shown that how to identify on the CT scan. Neuronavigation and carotid Doppler, yes. For if you are beginner, if you have it, good, no problem. That's actually as a navigation. In complicated cases, redo cases, you should have it. I mean, this is very life-saving things for patient and you also. These are the anatomy that we went in. Like I'll just go like this have pictorial view how you went in yesterday, right? Different kind of sella. Then this ground lamella that like you saw it yesterday, right? So this is the anatomy. We'll see in the detail in the next talk. And coming to the extended approaches. So this was the basic thing that you did yesterday. Today is like your talk will be like you have to see, you have to go into the anterior. So I'll be focusing on anterior cranial fossa regarding its approaches. So I will talk regarding anterior cranial fossa. Dr. Raudesh will talk on the lateral skull base. What we want to intend yesterday, this was the yellow, we wanted, like we went for the sella. For transplanum and transtubercular approach, we have to address this area. So your position matters, like when you are anteriorly like focusing, your patient should be extended so that you can approach there. So that is another important point. In axial view, you can say that like this is sella. Anterior to sella there is tuberculum and planum area, so this is the approach we want to see it. You can see it here, it is like this rhomboid size, it is not direct rectangular. Anterior to it, it will be transcribriform approaches, and this is a transclival and the transpterygoid. This is area of focus. Again, going into the sphenoid sinus, go to the sella. This is sellar approach. You work anterior to the sellar limits like tuberculum and the planum area. It will be called transtubercular approach and transplanum approach. Similarly, again, another ideology. You see this is clival recess. This is the sella. This is tuberculum sella here, and this is the planum area. Again, lateral OCR, medial OCR, carotid artery, optic protuberance, as sir has shown that optic, like there will sulcus chiasmaticus here, optic now starts, protuberance go into the orbit. You have this area where you have to work, and this is necessary for tumors which are extending into the anterior cranial fossa, that like two cases that I have shown earlier. One thing, if patient, especially then other pathologies, like if you are operating on craniopharyngioma, meningioma, other pathology which are going into the anterior cranial fossa, then you have to do this approach. You cannot just open the sella and get it done. So it starts from the sellar anterior floor, you remove the tuberculum, and then you take this area off. These are the anterior and posterior ethmoidal arteries, that you will show into during dissection. Again on here, like this is sella, this is anterior pass, this is posterior ethmoidal artery. This is the area where you want to work while working, while getting extra access to the anterior cranial fossa. This is for transcribriform approaches. Another anatomical view, sella. This is anterior internal cavernous sinus, tuberculum sella that is removed. You can see this planum area. So this is optic now go here like that, and then this becomes your area of workhorse of the in this transplanum approach. And this is area where you have to operate. This is intracranial view. Like when you are operating from below, like if you are seeing from the top, this is the sella, this is the tuberculum elevation, this is the planum. So you remove this structure, this is like a optic canal. So you take this structure out and then work into the cranial cavity from this area. Position, like as I mentioned, rest of the steps are like more or less normal. You position patient, open the sphenoethmoidal recess. This is the flap is necessary for anterior cranial fossa. Extent of the flap, sir has very nicely shown, like how excess width of this flap can be taken. All psi appearance. Then you can have various septa. You have to flush all those septa to work around, as I mentioned yesterday. You start with the drilling, eggshell it, remove it, use the burrs and make it thin. Then another special technique for going for the transplanum approach, because like there will be anterior intercavernous sinus. Now when you are going for the pituitary, which is just extending anteriorly, and you want to just remove those, you feel that there is no transgression of the pituitary into the normal brain parenchyma or crossing the arachnoid. So in that case, you can just remove the bony part, transtubercular, and you don't remove the dural part. Even you can take it out. But like the first case, like which I said, like it's going into the anterior lobe, then in that case you cannot just pull things off. You have to officially cut the that dura. How to do it? If it is anterior intercavernous sinus, you take one this, if it is a sella, you take two cuts, one anterior and posterior to the intercavernous sinus, you coagulate it and then cut it so that this corridor opened up, and then you widen it. If you don't do that, then it keeps bleeding and then it causes a troublesome problem. This is the only time where you can actually secure it nicely, otherwise you waste a lot of time. Like this case we have published, like you see that this is the area you went, like it is going into the area, like we have removed the tuberculum and this was Rathke's cleft cyst, and then once you remove it, you can see whole anatomy like this. This is like, we are just for the reference, you can see that what lies there into the transplanum approach. You can have optic nerve, ACAs, and rest of the structures, basilar posteriorly. Similarly, in craniopharyngioma, you cannot just remove with the normal approach. If you have a less opening, you create a more. Like yesterday we said, if you don't have adequate exposure, you are going to do a complication. Similarly, this is like we have taken a curse, we removed that anterior intercavernous sinus and then taken the tumor out. This is the part which is into the third ventricle, which is like easily smooth, but most of the dissection happens when you are dealing with the outer part of it. And then another important point is putting a fat and fascia and hadad flap. One of the most important thing, like reconstruction. Have a nice flap, work on it. So I'll show two videos. It will clarify one doubt. One video is like this was like pre-planned. This was transtubercular without opening the dural sinus. There was some flow white, so I thought like there may be facial, so we went ahead with the proper transtubercular approach. For that we took a hadad flap. This is the same thing, like we decongested, we went into the coena, then this is ischion tube, fossa Rosenmuller. This lateral part, again we have shown this anatomy yesterday, uncinate process, hiatus semilunaris, bulla, then we have coagulated at the base of middle turbinate, went through the lie of the ground lamella, and then making sure that we don't go too posterior, we remove the middle turbinate. Then we release the hadad flap. You can see that you have to be gentle, otherwise you can damage the flap. So I went in, put it into the nasopharynx, then disarticulate the posterior nasal septum. Then widening of the, you can see the bilateral ulcer appearance. Then wide spinotomy, like we did the shoulder osteotomy as we have mentioned earlier. Removed the rostrum. Then another part, like as I have to work, then proper extension of your anterior face of the sphenoidotomy. So we removed it because ultimately, because this was a giant tumor. So if you can see that if I am working around, this is the whole tumor. So I had taken wide sphenoidotomy. Then do the drilling of the sellar bone, eggshell it. This is the tuberculum part which I was removing. So I removed only the bone. Again, like this is the tuberculum sella which I am slowly drilling. You do the bony work before opening of the dural, before dural incision. You widen the sellar opening to, so that you can, like in normal pituitary and cadaver it looks like very small, but in giant pituitary everything is laterally displaced. So you can use navigation, you can use the Dopplers to for all your help, but I mean like this, like we are using the Doppler. Again, I have just opened the tuberculum, but I have not taken off the dura from. Like is the normal opening, like we open on the lower half of the pituitary or tumor. Then rest of the process is more or less same. Like you take it out, you go on the lateral side, first posteriorly, then bilateral cavernous sinus, then posterior and up, and then finally anterior, and then we go for the repair. So as we are explained, like I'll skip this part. Sometime as sir said, like there can be a premature bulge. You can use the cotton patty, you can lift it up, and then again keep searching for the corners, and you will find residual tumor. One of the points yesterday was like you can, like if you anticipate that there can be a premature bulge, you can put the lumbar drain. People sometimes can do a controlled drainage of the CSF by tapping it, but I mean, So if you see here, like while removing that, this was the tumor, and suddenly like that tumor was removed. This is the normal pituitary, which is drape around the things, and then you go for the repair. So I was working around because there was no descent of the tumor at the arachnoid at this side. So I went and I was working around this corner to make sure that whole tumor is out. And then you put a Surgicel, fat, flap. You put a fat in that clival recess and nicely close it. There was no CSA plique, so I'm not worried, but I have split. This was the posterior, like I think there is no residue. So this is one approach, transtubercular. This is routine approach. Pituitary are very normal. You may not attempt craniopharyngoma and all, but this is good. This was like a long time DAP was done, the craniopharyngoma with Professor BSS sir. Again, quickly, like it's very small, just for the craniopharyngoma sake, like how you have to do it, like you again do the same approach. It's a quick video. You open the intercavernous sinus, you coagulate, same the images what I have shown. You cut it, and then you can use the flow seal. Sorry, one of the good point, like in these cases, they bleed a lot. You can't keep waiting by putting a Surgicel. So you can use the flow seal, is very handy and should be utilized. Then you go inside, dissect. It's actually more kind of bimanual technique. Don't consider that you are doing endoscopic surgery. You can just curate it and this one. You need a good assistant in extended, and you are actually, you have to recreate how you will be operating into the microsurgery. If you do that, you will be a winner. Otherwise, I mean, it will be difficult. You will get demoralized by the amount of time and complication that can happen. So once we remove that, like sometimes you have to do a sharp dissection. It can be attached to the stalk. You have to cut the stalk. All those decisions are the clinical and according to radiology and patient's condition. So we took this out, then put a fat, flap, and then reconstruct it with the flap. And this is another important point. Like, see, if I'm showing this video just edited in the morning, I mean, this patient had acromegaly. Patient was attempted, like this was attempted in some of the good center, reputed neurosurgeon. You say that team went in with the endoscopic, and what happened? If you observe, you can see in the MRI, this pituitary acromegaly, it is filling the sella and it is going into the anterior cranial fossa, into the plenum near the cribriform. If you just notice it. Similarly, into the coronal, from the anterior you start that there is a tumor is starting, filling in the sella. So patient has anterior extension. This requires transplanum approach. So this was operated, like this is the position. Yeah, I don't know, skip, but like if you see, like we have widened the sphenoidotomy. Another important point, if you can see, this is the whole sella. They had only removed some portion of the cellar floor. So if you go in and they have removed only small portion of the sella in the middle and then just taken the biopsy. If you are attempting acromegaly, taking only the biopsy, a small decompression won't work for these patients. So we have extended this, like as you can see here, we are extending our sphenoidotomy. Another important point, you can see that anteriorly the tuberculum were much deep. This sella was, sphenoid sinus was like, sella was extended anteriorly widened and there was a cleft. So to work toward the tuberculum was itself is a task. It's very red. So for transplanum approach, as I said, we will discuss earlier, like you take a cellular bone out and then you remove rest of the posterior ethmoids. You open the plenum area, you have tuberculum and the carotid bulge laterally. अरे लाइट बंद. So when it required such a big approach, like we had taken this tuberculum off, then this is the plenum area. Then again, like it was going laterally into the cavernous sinus, so we have to work and make sure that we remove all the area of the bone which hinders the instrument movement. You drill the septa which are going on to the carotids. This is the anterior part. Still, this is the upper part is the plenum. You can see that it is much into the depth. The sellar floor is here. It is going into the depth, and the tuberculum is lies at this part. So after removing the part of sella, then working near the anterior cavernous sinus, this is the tuberculum sella which I am drilling right now. You have to make sure that you take tuberculum sella, bilateral medial OCR, and then work, take the plenum out. Otherwise, you cannot remove this tumor. Slow drilling, paint-like drilling with your diamond drill is the key. You have to keep drilling slow by slow. So the bony work that should be done, once you eggshell it, you remove with this small dissector. Remove the sellar part of the tumor. Then work again on the rest of the tubercular part of the bone. Coagulate, cut the dura anteriorly. And if you can see that this tumor is going too much anterior to this, like in this, this is your tumor which is going anteriorly. So I was still trying to remove with the minimum dural incision, though I had taken a more bony opening, but it was not coming. So I extended the dural opening. Then you work, use suction. This is your optic nerve into the place. You can see this is optic chiasma. This is left optic nerve, right optic nerve. This is the sella. This tumor which was going anteriorly and going into the anterior cranial fossa is lying here. So now you are like, if you don't open that dura anterior to the chiasma, you cannot take this tumor out, right? So I'm actually, you can see this chiasma, and you have to open this and then hold the tumor out. You can see that it was attached to the ACA complexes anteriorly. So this is ACA. So from anterior interhemispheric, like we took that tumor out. This was perforator which was preserved. And then this require a good reconstruction, putting a Surgicel, making sure, because now you went in like unless you covered it, like it can create another complications. So we initially put a Surgicel, then took a fascia which like you keep under one. So it is called inlay fascial graft. So here the key is put Surgicel. You can, if there is a big cavity, you can put a fat, put a inlay fascia which is tucking all the way around. Then if there is a gap, you can again put a overlay fascia or the fat. Like as it was operated earlier, like there was no proper Hadad flap, but we tried to mobilize the flap from the available flap and the rest from the flap from the floor. So at least like we could mobilize that whatever available flap and put it there. I was worried about CSF leak because ultimately, I mean, like when there was no proper flap, but you don't have to worry. Sometimes you inlay fascia, outlay fascia will work, and many centers in Japan don't do the Hadad flaps. I mean, still it's okay, but the reconstruction, layered reconstruction, inner support, outer support is most important. So, I mean, this is just, I mean, overview of things like how to go for extended approaches, and many of other things we will explain you into the cadaver demonstration. Dr. Avdesh sir and Dr. Deepak Agarwal sir will demonstrate for these anterior cranial approaches. And if any questions, I can take questions. Otherwise, we can move to the next talk by Professor Avdesh sir. Yeah.
Okay, good morning. Once again, I am thankful to the Dr. Deepak and Dr. Dattaraj for giving me this opportunity. I am going to talk about endoscopic endonasal transpterygoid approach. So this is the sphenoid bone you can see, and the area of interest is this part. This is the medial pterygoid plate. This is lateral. तो कम चल रही है? अच्छा 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 कोई नहीं कोई बात नहीं इस बात में Here is also a small fragment that is palato-vaginal canal, also known as gombro-vaginal canal or palato-sphenoidal canal, through which pharyngeal nerve passes to the nasopharynx. So what are the anatomical targets which you can achieve with this approach? The first one very common is lateral recess of the sphenoid. So you might be wondering, some people, what is lateral recess? Let me explain this. This is a CT picture of the coronal cut. You can see here. This is the medial and above that, this is pterygoid body. Okay. You can see here. This is the medial one is the median canal. The lateral one is the femoral tendon. So in a usual scenario, you can see the pneumatization of the sphenoid sinus, which is limited to the sinus only. When the pneumatization extends and involves the this becomes lateral recess. And with that situation, the median canal and the femoral tendon, they fall apart. Like here they are close together, sometimes they touch each other. And here you can see the both of the foramen. This and this one, they have got separated. So this area is known as lateral recess. And when the leak affects here, the pseudomorphism is here. So by midline approach, you can never see the area of defect. So to approach that defect, you have to till this pterygoid body process and see where is the defect and then pike it. That's otherwise there will be recurrence of the leak. So this is a major indication which we neurosurgeons see. Most of ENT colleagues see also. And this is axial cut. You can see this is the posterior wall of the maxilla. This is the area known as pterygopalatine fossa. And you can see here, this is the median canal, and this is the vombrovaginal canal. This median canal comes from the carotid canal. You can see this carotid canal starts from here, goes to pterygopalatine fossa. So I think this anatomy has to be understood by us once you dealing with the lateral recess or transpterygoid approach. So other part you can assess is the cavernous sinus. For true cavernous sinus lesion, many times you do not require this approach, but many times this cavernous sinus lesion, what happens, they extend into the infratemporal fossa or middle cranial fossa, then this approach is required. Like if it is limited to only the cavernous sinus, you can get away with the midline approach. But if it extends to middle cranial fossa, like many times what happens in invasive pituitary tumor, the tumor goes lateral to the cavernous carotid, then this approach becomes important. The third thing, you can assess petrous apex also with this approach. Infratemporal fossa can also be assessed with this approach. And when you attempt infratemporal fossa, then what you have to do, you have to use the modified Denker's technique. Our NT colleague knows this better, where you do not only do medial maxillectomy, you remove the anterior wall of the maxilla also, and you get thorough view of this area. And of course, lesions in pterygopalatine fossa you can also assess with this approach, although in that case a drilling doesn't require, the lesion comes anterior to it. But the target, the corridor is the same. If there is any question, you can ask. I think this should be very interactive. So what are the key steps in this procedure? You have to do medial turbinectomy, and please remember that Hadad flap in this situation is taken from the opposite side of the lesion, because you are going to coagulate the sphenopalatine artery and the flap will get compromised. So the flap should be taken from the opposite side of the lesion. You have to identify, yesterday I told that how to open the orbit. So in this situation also you have to do ensinectomy, bullectomy and all these things, posterior spondectomy to reach this area. Although this thing should be tailored. If the region is very small, then you may not to do it, like in lateral disease, only lower part should be done. Otherwise, usually most of the lesions are large, so you have to do it the anterior posterior spondectomy for this procedure. Then you have to identify the sphenopalatine artery. You remove the posterior wall of the maxilla and expose the pterygopalatine fossa and its content. You lateralize, medialize it, and then identify the median nerve and the maxillary nerve and drill the pterygoid base. So these are some anatomical photos I've taken from Neurosurgical Atlas, just to clarify, give a better view, better understanding. You can see here, once you see the go inside, you see the infrared turbinate, middle turbinate. Yesterday I told that you medialize the middle turbinate, then after you see the uncinate bulla, and then you do see the remove the uncinate, you see the maxillary ostia. And then after you open the maxillary ostia, enlarge the opening, you see the maxillary sinus posterior wall. Then you identify this perpendicular plate of the palatine bone, and then you identify their perpendicular palatine bone has two processes. One is the orbital process, goes to the orbit, another one goes to the sphenoidal process. In between them, there is a sphenopalatine foramen. Through the foramen, sphenopalatine artery passes. You identify and cut it, and medial to that, then after you will get the pharyngo, this vomerovaginal canal, and just lateral to it, you will get the median nerve. You identify the median nerve, and then after identify the median nerve, and then after you cut the median nerve, and then lateral to that you will find the foramen rotundum, and you see the foramen rotundum, you see the median nerve, and then once you medialize it, lateralize it, you see the foramen rotundum V2, and this area becomes the pterygoid process, and you drill it, and after that you will see the temporal dura, middle cranial fossa, and deepen it, you see the V3, and then approach. This is basically normal anatomy. And what happens, I will show you some case, then after you know better. So this case we operated, this was chondrosarcoma. You can see the tumor is filling in the sphenoid sinus and reaching up the pterygoid process. So once you go you have go midline and the pterygoid process, both approach combined together, you will see this bulge. So this itself guide you. In normal situation, if this bulge is not present, the surgery may be difficult. But in selected cases, when this bulge is present, this bulge will guide you, and many times you do not require any navigation to do these type of cases. This itself will guide you where the tumor, and this make space to take out the tumor. So I will show you a video. This patient had right side hemifacial pain numbness and right temporalis and masseter weakness. You can see here this is the tumor in the infratemporal fossa involving the lateral recess area going up to the lateral wall of the sphenoid sinus. Okay, pterygoid process. This all you can see in the CT. This lateral pterygoid plate is destroyed. Basically, this was the V3 sonoma. You can see here the foramen ovale has become very large. So once you open the lateral recess area here, you will see the tumor. So this is the video. So what I am doing, this lateral inferior turbinate. Sometimes we cut the posterior 1/3 of the inferior turbinate to increase the exposure. This can be very well done without any problem. So please remember that at the posterior end of the middle turbinate and the inferior turbinate, if you make a small incision, this is the area of the sphenopalatine artery. Many of our NT colleagues, when for sphenopalatine ligation, they take this landmark. The end of the middle turbinate, end of the posterior turbinate, you make a small incision, you will get the sphenopalatine artery. So this was done in this procedure. You can see we encountered the sphenopalatine artery, we coagulated it, and now cutting the posterior end of the middle inferior turbinate, posterior 1/3. Now middle turbinectomy is being done. This is an ancynectomy being done. Then bullectomy. The superior turbinate, sphenoid sinus opening, enlarging the sphenoid sinus. Then after widening of the maxillary sinus, this is posterior of the maxilla. This all thing you will see in the demonstration with the cadaver. This is the making flap on the opposite side, adult flap. This is the posterior wall of the maxilla. Removing the posterior wall, now exposure of the pterygoid palatine content, then drilling of pterygoid base. This is the cutting the median nerve. You can see this is the median nerve and this is the V2. This is pterygoid process. So pterygoid process has been exposed. Now we are removing the bone. Because the tumor was present behind it, probably this was the lateral recess through which tumor has gone. So I am drilling the pterygoid body. And once you drill it, the tumor is exposed now. Now dissecting the tumor, traction and counter traction. Schwannoma has very good plane. This is infratemporal fat. And this is the, now the tumor is being removed. So this is the cavity packed with fat and with the nasoseptal flap. So this is post-op imaging, the tumor excised by schwannoma. This another lady, she has cavernous sinus lesion. Patient had lateral palsy leading to diplopia. You can see the lesion. This is the video. We are remove the middle turbinate, inferior part. Then after doing ancynectomy, you see this ancynectomy, bullectomy, all these things done to enhance the exposure and instrument maneuverability. Otherwise, the area target is very focused. But if you do not make the space, the instrument maneuverability will be very difficult. So now bulla is removed. The maxillary sinus, this is sphenopalatine artery. You see, this is the nodal process, this is the orbital process. In between, there is a problem. So we coagulated it. And the posterior wall of the maxilla is being removed. Then posterior smart ulcer open to increase the exposure more. Then we open this splenic sinus. You can see this posterior smart artery. Now making a small flap to make it binostril on the same side. So the posterior maxillary sinus wall is open. And after that, making a rod flap on the opposite side by lateralizing the inferior turbinate, middle turbinate.
Circle.
This is superior inferior incision. And you can see this is the posterior wall of the maxilla. This part will be opened to assess the lesion.
Perpendicular plate is completely drilled off.
Yes, perpendicular plate you have to drill off. Actually, you can, depending on the lesion, you have to approach things. First, open the maxillary ostia. Then after you, I will show in the cadaver. Just break it. It's medial, it's very breakable. Just break it and see the enlarged maxillary sinus opening, maxillary ostia opening. Go up to the posterior wall of the maxilla. You'll see the posterior perpendicular plate of palatine bone. See the sphenopalatine artery. Cut it. Then remove the posterior wall of the maxilla. You will just behind that you will get a periosteum covering the pterygopalatine fossa content. Okay. See on the medial side. See the vomerovaginal canal. Just lateral you will get median nerve. Cut the median nerve and lateralize the content of the pterygopalatine fossa. Expose see the V2 between that area V2 and median canal. Just drill out the pterygoid process, and after that you get middle cranial fossa. And at the same time, median, if you drill it, that is for middle cranial fossa. If you want to see foramen lacerum and everything, follow the median nerve. It will take up to the foramen lacerum. Okay, you'll see in the cadaver. Actually, this procedure is very good for bony lesions, particularly chondrosarcoma. Okay. So, and I think this is the ideal approach because the tumor itself gives way. You just see, attack the, make the exposure. You'll see the bulge. Go around the bulge. Go inside. Take out the bony part. You'll remain because it's bony tumor. You'll remain extradural. The only problem is that you should be beware. We should be locate the where is the carotid, and go try to manipulate that area in the last. So if you see these landmarks. And then probably navigation also not required much time. Navigation is only required when in the recurrent redo cases, probably what we believe. Otherwise, if you do not have navigation, even then you can do these procedures. But you have to rely much more on the natural landmarks which are available there. Yes, Doppler is important, particularly in those cases when the artery is encased by the tumor and is not seen outside. You have to search for the artery, then only Doppler becomes important. Otherwise, there is no fun in using Doppler if the carotid is seen already. You just take the Doppler and you'll see the Samava, ju. It's not a good thing because the artery is already there. You are yourself is seeing it. The Doppler becomes important when the artery is encased by tumor. You are not seeing from anywhere. You have to take out tumor very carefully and put Doppler everywhere, see where you search for the artery. Otherwise, if the artery is already there, then there is no fun in seeing it. Anyway. So we are dealing the median canal, and this is the median nerve, and this is the V2. You drill out this area. Okay. The PPF content has been transposed. Now we have exposed the pterygoid process. Actually, posterior wall of the maxilla, open it, periosteum of the pterygopalatine fossa. Identify median nerve, transpose the content of the pterygopalatine fossa, you will see the pterygoid process, Then you drill it. Then you see the middle canal fossa. This is pterygoid process. That's why I told you, ipnopattern artery is a landmark, median is gender landmark, V2 gender landmark.
So, median and
This
V2
you
are
fill the median here, this will take you to the prominence.
correct. But this, for the PPA, what is the landmark? How do we identify?
Pterygoid fossa. Pterygoid fossa posterior of the maxilla. Ipnopattern artery cut it, you see the posterior wall of the maxilla. Just increase the take a cut and remove the posterior wall of the maxilla. You see the pterygoid fossa.
So this is, we are inside the pterygoid fossa right now, looking at these two structures.
Yes. This becomes very easy if there is presence of lateral disease. But all these things are you see in the normal anatomy. In pathological anatomy, it becomes very easy because the tumor is already made space for you, and you can see the tumor immediately once you go there. Like you have seen the in that case, the bone was eroded. You see the bulge. So we have exposed the sella, sphenoid sinus. Some more bone removal. See, this is the sella. आगे बढ़ गया है. Anyway, so we may have make incision over just below the V2. There are some bleeding, controlled with solubilized gel foam solution. Then internal decompression of the tumor, separating tumor from all around. There was a rent underneath, which was packed with fat. You see, this is very important to avoid CSF leak. You have to find out where is the rent. The arachnoid rent or diaphragm rent are in the inside. The dural defect is outside. So you have to search for where is the rent, plug it first. Then after plug the dural opening. If you plug only the dural opening, the CSF keep on coming and the repair may fail. So identifying the rent in the arachnoid and the diaphragm is very extremely important. So you may sometime have to search for it. And many times what happens, if you see the rent, you keep try to plug it. So what happens, you try to plug it, the rent goes behind, the plug is over it. It didn't plug, truly speaking. So for that, you have to plug, the fat plug should go inside, then after you take it outside. This ensures that fat has gone inside. Otherwise, what happens that the arachnoid will be pushed by the fat, and then you plug it, thinking that the fat might have plugged the arachnoid rent, which it actually has not done. I hope I am clear. So this is a major cause of failure. So you have to see the arachnoid rent, plug it, then after put some reinforcement fat over it. This ensures, I think, better dural defect repair. So putting nasoseptal flap over. So this is another case of CSF leak, lateral disease. You can see here. This is the defect. So by midline approach, this is not possible to see that where is the defect. So you have to drill this part, see the defect, and plug it. So it has been done. This is the defect side, which has been plugged.
So in this, we first moved the perpendicular plate, went into the pterygoid fossa, and then the pterygoid process.
Actually, in this case, the pterygoid body, because this is lateral disease leak, so its bone is not compact and thick. It's already pneumatized. So only small, you can take upcut and just delineate it. Actually, what happens, the transpterygoid approach is not isolated. It is combined most of the time with the midline approach, transspinal approach. Okay, so this should be clear. You do this transpterygoid approach rarely in isolation. Many cases the tumor is large. You have to open, like in this case, you go midline, you see only this pseudomonal you see, tip of this. Okay? When you go with this approach, you combine both things. Okay. This will follow to that area. Then you see the defect, take out this pseudomonal and then put fat plug.
So in this case, there was bilateral electrolysis.
Lateral yes. You see, this is the median, this is the V2. I just wanted to show that people should know what is the lateral lysis and what is the lateral lysis leak. And this should be the ideal way, because you have to see the end on view of the defect to treat it properly. This case is the chondrosarcoma, very good case. You can see the bone was eroded. We do midline approach and transperiod approach. The whole tumor is exposed and we took it out. This is another case of chondrosarcoma. You can see the bulb. This naturally guide you where is the tumor. Irrigation probably tells you where. If where is luxury. You can see here the same thing. Here the tumor, this is IPA. Tumor has gone beyond there. Okay? But if you have good exposure, you can take it out. So what has been done in this case? This is another patient. You can see here this is the bulb. Okay? This is the bulb. We did both midline and lateral approach, and the tumor was taken out.
On the MRI, how do you identify the?
We get the CT scan. I didn't have the picture of it, unfortunately.
Can we do anything on the MRI? Can we see the rotundum and the median node canal nicely here?
I think bone anatomy is not well seen here. But in this case, we had CT, but unfortunately, I didn't have right now. But you get in normal pituitary, we do not get CT PNS, but in these cases, we often get it. This is a case of JNA we did with our ventriculic. Very wide exposure. A small part was left, otherwise it was removed completely. So this endoscopic, sorry. Usually JNA comes to us with a very large tumor, and in this approach you do multi-compartmental approach, like we do Denker's procedure. What is Denker procedure? I don't have fiscal here. Actually, there is something known as piriform aperture. We have this nose, this soft part of the nose, and the bone is like this. So this area, bone is known as piriform aperture. So you have to identify the piriform aperture, go immediately to the medial and do medial maxillectomy, go laterally expose the circ nose better, expose the anterior lateral part of the maxilla, then cut it, and then you have a huge exposure. So this is known as Denker's procedure. And JNA, in JNA, you have to go all around, just like hemangioblastoma we operate. You go all around. This has very good plane. So keep on separating it. There is one instrument known as coabulator. It's extremely useful in these cases to avoid bleeding. And just take it out. It comes out very well.
So my question is, for JNA, we used to do a combined transperineal transcranial. So we can just do a transcranial, leave that part there for gamma knife.
JNA is limited to nose. Rarely go to transcranial in cavernous sinus.
When it comes to us, we are always doing a combined approach. I can go to bigger cases. So if you go back to the previous slide, so in patients with this, which are coming into the bilateral cavernous sinuses, also frontal region also, where we can leave this portion which could not be removed.
Any tumor is left when you are not able to remove it. But if you get a good plane, take it out.
No, yes.
If you are not able to remove, then always you can give radiotherapy. We send it for radiotherapy, not for gamma knife. But many times you get a good plane. This is extradural tumor.
We can see that expose the nasal cavity, and then you take out the enteroscopy you do, okay, canine fossa, then you join the two, nasal cavity and the antros. So it becomes a big cavity, whole of the nose till the septum, and laterally till the this fossa. So it gives very big exposure. Yes, but large tumors is good enough.
Yeah, thank you very much, sir. Very nice lecture. Any queries, questions? So we can move to the last part of the morning lecture sessions, and which is one of the most important talk. I mean, how to get away after opening a big skull base. So I request Professor Deepak Agrawal sir to have his talk on skull base reconstruction and complication avoidance.
We can have questions tonight.
Any questions to the faculty? Or yeah.
Question is to Jaiswal sir. Sir, you said that you need to go to the pterygopalatine fossa, you need to remove the perpendicular plate of the palatine bone. Is it to communicate the pterygopalatine fossa with the nasal cavity because it forms the medial wall of the pterygopalatine fossa? So, because you add the midline and then the paramedian approaches because the tumor was involving both the compartments. So the question is, you'll have to remove the perpendicular plate of the palatine bone. If the pathology is restricted lateral to it's only in the pterygopalatine fossa and lateral to it, then you still need to remove the perpendicular plate of the palatine bone. Okay. Okay.
There are two things. One is to accept the tumor, to remove the tumor. Access may be easy.
Okay.
But remove the tumor, you have to manipulate.
Okay.
And depending on the nature of the tumor out. Some people may remove free space. Some people will remove organ, like hearing. So depending on that, you have to do it. But yes, in all the, if you are going through nose, so naturally you are communicating anything with the nasal cavity.
Okay. Thank you, sir.
Just give me a couple of minutes. I'm just
coagulate the sphenopalatine artery. So, what we have realized is if you don't remove that bony, the spicules there, it's very difficult with the bipolar.
It's, usually sphenopalatine artery has not one artery, many times it's two arteries or three arteries. So we have learned from our NT colleagues, just expose coagulate. We have been coagulating many things, so not much problem. You have to identify it.
Because they take out the bone as well, plus they are only using that
Bipolar also it's not so difficult.
better to take out a little bit bone.
Yes, you have to expose it.
Because you are seeing it, but you are not able to reach it because of bone. Bone doesn't allow your
Yes, actually, you identify the sphenopalatine foramen, take a 1 mm upcut, enlarge the opening, then coagulate it. Okay? So, and coagulate it fully, so that it should not bleed. Somebody asked about CSF optic nerve disease fenestration and CSF leak problem. So what we get a lot of patients have idiopathic intracranial hypertension, so we do a lot of optic nerve sheath fenestration. So if you do fenestration, CSF is invariably to come. In fact, is a very good marker that your job has been done. And then at the same time, it will lead to meningitis also. So what we follow in our institute, these patients, we do optic nerve sheath fenestration only in cases when there is a vision is significantly deteriorated. If the presentation is only headache, we do thicoperitoneal shunt. If the vision has deteriorated, many times these patients also have headache also, raised pressure. So we do either in the same time we do lumboperitoneal shunt also, or we do continuous LP drainage to avoid CSF leak through the nose. So that's how we overcome it. Otherwise, it's very difficult to prevent CSF leak from optic nerve sheath fenestration if you do not do lumbar drain. Because if you make a fenestration, you cover with fat, CSF will keep on leaking. There is no place where you can somehow वो क्या कहते हैं कि फैट को फंसा नहीं सकते कहीं किसी आसपास में. है ना, वो फैट वहाँ रुकना चाहिए, कैसे रुकेगा? So only way to reduce the pressure that you can do by either lumbar drain or by L patient, doing L patient in the same setting. And that solves both the purpose, because many patients, they have raised pressure also, and thicopatin should take care of that. Vision problem taken care by optic sheath fenestration.
Will that negative suction will increase the chance of meningitis? Because high pressure.
No, it doesn't happen. We keep on doing lumbar contours lumbar drain for many patients for high flow CSF leak. It doesn't happen.
If you are doing the thicopatin, then you require optic nerve fenestration anyway.
If patient has significant visual deterioration, it is needed. It is needed. It is needed.
All right, so I finally got my presentation. So, so good morning to all of you, and sorry for this. So as I think Dr. Avdesh and Dr. Datta has already shown you that after all these extended approach, skull base repair is very, very important. And I will be telling you a bit about the overview of all the skull base CSF leaks and what is there in our armamentarium. So as you can see, this is one of the extended skull base approaches which has been done. You can see the chiasma, and it's an extended approach. There's a big defect. So obviously the nasal septal flap or the Haddad flap remains the workhorse for all these extended repairs, and it's based on the sphenopalatine artery, as we know. And yesterday we also got to know that you can use fluorescein angiography to make sure that the vascularity is retained when you are doing this for large defects. However, there are disadvantages with everything, and there are disadvantages with Haddad also. There's a necrosis because again the vascularity may be compromised in certain cases, and because you're removing so much of mucosa, that mucosal defect heals very slowly. And one of the major complications or issues the patients have is of nasal crusting and a feeling of nasal obstruction. Very difficult to manage, in the outpatient department. Also, in up to 14% of the patients, we might have, septal perforation. Obviously, we have created perforation also, and it may further extend with collapse of the nasal dorsum in certain number of cases. So these are also major cosmetic issues which patients may have following Haddad flap harvesting for these surgeries. So as Dr. Avdesh just beautifully showed, there is the gasket seal technique. So we have the classical gasket seal is that first you put a fat graft. This is the dural margin.
There was not gasket seal, that was bath technique actually. That's classical gasket.
So I'll talk about both the techniques with Dr. Avdesh said. There's a fat graft, then we have the fascia, then we have a buttress. This buttress can be a piece of bone or any other material you want to put here. After this bone, because this bone is going under the normal bone of the defect. So this is the main, and that's why it's called a gasket seal, because this fascia is coming on either side, coming out. Then you put the nasoseptal flap, and then you put your glue. So this is the classical multi-layer technique to close these defects. What Dr. Avdesh just said, the bilayer button technique. In this, we have the fascia, we put a stitch between two pieces of the fascia. One part is put superior to the dural opening and one part inferior to the dural opening. So this is the way these two are going. And after that, we have the standard nasoseptal flap. So this is the bilayer button technique. Then is the most common thing which we use is the fat, and then we put a flap with a tampon, and you may put it with a glue or something like that. There are various alternate options, and people have also tried other facial flaps in those cases where Hadad is not available, pedicled on the superficial temporal artery. In addition to this, you obviously, for very big lesions and for high pressure leaks, I'll come down to high pressure leaks little later, you can use which is used very commonly in the emergency department, for any bleeding also, where we can put a Foley's catheter and inflate it. And there is a inflatable Mirocell also available, although I have not personally tried it. And we can suture the fascia to the edges of the dural defect. In fact, people have sutured the dura itself, and we have people from PGI doing that. Then obviously we have the two major adjuncts, which is again most important for us, which is the fibrin glue and the lumbar drain. So I think the fibrin glue we are all using anyway copiously. Lumbar drain is a very important adjunct which should be used, I think, more magnanimously than we are doing right now. Then the newer techniques, there is a clip device which was introduced. This is the Japanese thing, where similar to the clipping using for the intestinal clipping, we have this device which actually clips the end of the dura with the graft. So it is easy to use. However, it's not available here. Then we have a U-clip. This is by Medtronic, which are self-closing sutures. So you put those sutures on either side and you press it, and it has already a memory shape so that it makes it into a suture. Then we have the umbrella technique. This is a device which was developed for cardiology, for interventional cardiology. This is, and it has been there since 1974. It's by the name of Amplatzer by Abbott Medical. It's a self-expanded double disc mesh. So it comes inside a stent, and when you release it, it becomes a double disc, and inside is like this and outside is a smaller disc. So you put it inside and you just release it, inflate it. So there's a two discs which will capture the dura in between in the defect. And it comes in two sizes. The video, unfortunately, I just cannot play. So cadaveric study has been done with the device for pituitary defects. And this was done just recently, 2-3 years back in Italy. So there they have shown its utility. It's very nice. It's available in India. There are two sizes, 10 mm and 22 mm. This is on India Mart, I found out. And it's not that expensive, 30,000 to 50,000 rupees. So you just put it there. And 22 mm is quite a nice 2 centimeter wide. So major defects you can put it in, and there is no inflation also. They are just, it's like an umbrella, two umbrellas opposing. And then you can start it's like a bi-layer button technique without using anything. Then what I personally started doing was I was just looking at other ways these were not available. And because of affordability and everybody cannot afford a 50,000 device, and we didn't have anything. Glue is also expensive. So what we devised was the aim stick, where we use the mini plates. I think in every OT we have these very easily available. And we tried to try different plates. What we found was the simplest thing is you take a 4-hole mini plate, or you cut a long mini plate into 4 holes, the most malleable one, and using any endoscopic instrument, you just put it inside, and I'll show you. And the advantage of this is the screws are self-tapping, and the screws come in very nice, I would say, configuration for skull base repair, because there are 2 mm and 3 mm screws available. So they do not penetrate too deep into the bone also. And very low profile screw. Also a bigger advantage is the screwdriver which comes, it is already designed so that it can be easily removed. So you can easily insert and remove the screwdriver. So there is nothing required extra. Already everything is there. And this is what I had a video, but unfortunately I can't show it now. So this was a large defect. We can just put a screw here, and you put this plate here, and just wherever you feel is there is bone here, you put one screw here and one screw here. Using the same screwdriver, you need a longer handle. That is the only thing, it goes inside the nose. And we made couple of videos with it also. So we have done 4 patients. The advantage is that high pressure leaks, there are 2 kinds of leaks. There is a low pressure leak and there's a high pressure leak. In the low pressure leak, you can get away with anything. There is no problem. The chances of actual CSF leak occurring is less than 1 to 2%. High pressure leak, on the other hand, is the most difficult thing. And in high pressure leak, where there is direct communication with the intracranial cavity, like all these extended transfemoral approaches which we do, their chances of CSF leak dramatically increase to 10 to 15% or even higher. And 10% or 15% is a big number. These are the leaks which are leaking despite your best efforts. This is not that we have left it open and it's leaking. This is despite putting lumbar drain, doing all these facial techniques and everything. So for this, you need a buttress from below. So once you have that buttress, then only the leak will stop or will be prevented. So there are 2-3 ways people have said. Either you primarily close the dura, that is one way. So you have a buttress there, or you put in something which is fixed rigidly. So I think this technique helps. And after you put the plate, then you put the Hadad flap over it. So there is no exposure of the plate. So it's Hadad goes over it and the glue goes over it. So it's a very nicely sealed system, and titanium already, the standard plate, it's approved. There is no issue with it. So this is just to tell you about our the different methods and what we are doing with the skull base. Thank you. Any questions?
Yeah, thank you very much, sir.
No, I said it's not exposed to the nasal cavity. You are putting metal plates everywhere. And everywhere we are putting in titanium, even in the most infected regions. So that is hardly a problem. That is not. We have followed. We have 4 patients we have done. They're all fine.
But yeah, very nice, sir. And another way, like just looking at you, we can add the absorbable plates like that craniosynosty that people put, which can be absorbed.
The reason we, of course, we can.
Under Ayushman, don't do it.
We can definitely use that. But what I'm saying is, this is almost free. We thought of a.
Yeah,
I would say option
some
which is almost
thoughts on innovation. So very nice. I mean, you have covered all the things from old to the newest one. Yeah.
Now I'm working with somebody to make it. What I've thought of is, you take 2 4-hole plates. In the center, you put a stud so they can move around. You put them together, just turn it around. That is difficult to insert inside. Through the nose, how will you put it? Only this, where it becomes, or there put an umbrella kind of a device which is there, or you put in this. This is most easily available, no regulatory requirements, nothing. You take a plate and put. How will you put them inside?
No, sir. The problem is like putting inside the nose. If the bigger size is required, putting inside.
Right.
छोटा वाला चलेगा.
It's not easy to put inside the nose. You have all the turbinates and everything coming, even the plate gets stuck. So unless you do every turbinectomy, everything is removed one side and you have this big hole, then only you can put in something which is a burr screw, burr cap with at least 1.5 centimeters in the diameter. 1.5 centimeter is not easy to just put it like that inside. That is the only issue.
Yeah, 1 minute.
Sir, how do you say it's a high pressure leak? Excuse me, sir. How do you say it is a high pressure leak? Just because it is, you are open the ventricle, or?
Yes, if you have to put the ventricle, or there is definite criteria to distinguish high pressure and low pressure. If there is a arachnoid tear, then it is, or a small through a pituitary, then it is not considered high pressure, it is considered low pressure. However, if in any extended transfemoral where opening up the dura and exposing the intracranial structure, then it is considered a high pressure.
Yeah, thank you very much, sir. Very nice lecture. So just like I was going through my presentation and then I stopped on showing cavernous sinus. So what you are like, sir will be explaining all. I'll just show the images which you can see in the cadaver lab. So 1 or 2 images. Yeah. That one. So that sir has covered well. This is another that you are going to see it like opening of pterygoid canal, Vidian nerve. Another thing is like same Vidian nerve. This is pterygopalatine fossa. Focus point, pterygopalatine fossa. Another things like one important point you have to see is like while drilling it, like you have to drill around the Vidian nerve. You don't have to go medially and up. So that we have to take care. So after that, like sir, like we have covered anterior cranial fossa, we have covered transpterygoid approach, and anyway, once you go for the transpterygoid, you will be opening the clival carotid, and we will be going into the cavernous sinus. So we will see the whole length of the carotid. Yeah.
You see, this is the median nerve.
Yeah.
If you follow it, it will go to the femoral level. It's clear in this picture.
Yeah, you stay here. Like some of the, you have to explain some of the images. Yeah. So this is what will be in the cadaver demo. Like you will be seeing the whole of the clival carotid. Then it is going forming posterior genu. Then another horizontal part, anterior genu going inside. So this is your like cavernous area. This is your transpterygoid area, right? Going into the middle cranial fossa. This is your cavernous sinus. You can see the distal ring. You can see the proximal ring here. And once you take this periosteal and cavernous sinus dura off, you will see these structures. What is expected to see is like once we lateralize things, you will like in transpterygoid we will see the Jesserine ganglia. Okay? Then V2, V1, and the rest of the structure will be in the cavernous sinus. So once we take it off, you will see the V1. Once we start mobilizing the carotid, like you can see the sympathetic plexus along with it, and then the 6th nerve. Yeah, and this is the another diagram. If you take it like lateralize it from the top, you can see the 3rd nerve, 4th nerve, just behind and below the 3rd nerve, and then you can stress out the V1 and V2 branches. Same. Carotid 6 now. So I mean just for your pictorial presentation, because this is what you are going to see it, relate yourself with that, and during cadaver demonstration you will have the same. So we are at the end of this lecture sessions. We will quickly break here. We will have a group photograph and then we will have a tea before we start our demonstration. Thank you very much.
All of you please come back. Rati, Thank you.